a very healthy, happy new year. And this is where hopefully you're able to get a lot of your questions answered. And again, the purpose here today is to share with you what is objective evidence. That is evidence from what is the manufacturers directly, and also from what the FDA has informed us, and certainly most importantly from what the patients are talking about, such that you end up getting the many answers that you need. So I just want to go ahead and start off by saying the first phone consult that I did of the year was that of a physician. Actually, she is an intensivist and ICU doctor, and she sought one of the exceptional medical center plastic surgeon, and she ended up getting her explant, but the capsules were determined to be very thin, and her plastic surgeon ended up unfortunately cauterizing the capsule directly on top of the rib. And now, as you can imagine, the task for me is to remove that capsule that is essentially being burnt off at irregular areas, especially in between the ribs, on top of the rib. And it is certainly a much more challenging surgery than, let's say, had she had her implant and capsule. And as you can imagine, removing kind of a wet tissue paper that's been partially burnt off sporadically on and off, for me to be able to tease that off of the chest wall. I also talked to another lady just this year alone, and she at age 21, believe it or not, ended up getting a lift operation, which this was very early on, and a patient who was essentially planning on having a family and having become pregnant, as you can imagine. And she ended up getting a lift at that very young age, not a reduction, but a lift. And this is where, unfortunately, as you can imagine, she ended up getting what is a very much unnecessary surgery. Today, I saw many of my post-op patients, three that were 6, 7.5, and 7 weeks post-op, and I discharged them. And neither one of them, they were 55, 52 years of age, and another one in her late 40s. And despite their augmentations, did not need what is that unnecessary lift, and certainly not the drains as well. Now, one take-home message for me, for the many patients, is number one, do your homework. Be well read. Know my mental process. Know what my thought process is. As a patient, you need to be well read on your surgeon to understand what he or she is thinking. What is the goal of the surgery? Number one, do your homework. Do not rush into the surgery. Do not give in into the fact that the insurance is going to cover this, and that you're seeking the surgeon out because that person is going to take insurance. Now, remember, just today I learned the Medicare reimbursement in general went down 2.8% across the board in a time where inflation is occurring, and you would think they would end up paying and reimbursing the surgeons more. And if anything, not at all. It is not enough to compensate for the amount of time. So in my practice, I spent almost 4 hours plus minus removing the entire implant and capsule, which is a very average size implant, 350, 400 range. And this is where the 4 hours it takes for me to doing the surgery in the manner that I do. You cannot have insurance cover this because, number one, insurance doesn't recognize breast implant illness as a real entity. They do not recognize removing the capsule. And this is where you do not want to shortchange yourself. So the take-home message is, number one, do your homework. Do it right, do it once. And I'll say it again, do your homework, do it right, do it once. You do not want to be this patient where what I would call the most unfortunate case, where now she has to seek out another surgery, go through the healing process again, remove the residual capsules, which is relatively much more complex, and having to recover and the financial burden cost of having to do the surgery again. I've heard this sometimes from some patients where they said, well, I'm going to give my local surgeon a try, and if he or she does not do it, then I will go ahead and get the residual capsules. I'll tell you, sometimes it may not be the best case scenario. This one patient that I saw today in clinic, she had 3 sets of implants. The first set was silicone, and when her second surgeon went in to remove those silicone implants, the ruptured implant spilled into the chest, and now she had what was lymph nodes that were laden with silicone. And now the task was all that inflammation that spilled silicone, and you do not want to be finding out otherwise. And so do it right, do it once, and certainly do your homework. And the second thing that I want to impress upon here is, the patients ask, did you get the whole capsule out? And the answer by the surgeon should be not verbal. It should be, here's a picture of the chest wall showing complete removal of the capsule. That's the chest wall, the ribs, and the surgeon is not only showing high definition pictures or videos, but also a video of the chest wall showing complete removal of the capsule, completely, sincerely, definitively, wholeheartedly. You as a patient or a significant other or prospective patient must be able to enter your surgeon's mind and be able to understand him or her. I have had so many patients in 2024 and the years past that came to me, and when they saw me in person, they told me they already knew me. They knew my mentality, they knew my personality, they knew exactly what I was about. And this is that homework that you need to do, such that when you do sign up for the surgery, you have the peace of mind that two things are going to happen on your day of the surgery. Number one, your surgeon is going to remove the whole implant capsule, all of that inflamed tissue, completely, sincerely, wholeheartedly, definitively, religiously, and honestly. Because remember, this is the bond with you. And number two, that once all of that inflamed tissue is removed, it is sent to pathology to make sure it's not that rare BIALCL, which is that very rare lymphoma, breast implant associated anaplastic large cell lymphoma, and that all of it was tested and CD30 analysis was done, and that the patient has the peace of mind and the comfort that there are going to be no surprises awaiting the patient. Now, I want to go ahead and mention, now please feel free to ask any questions. I want to go ahead and take this. This is the journal, the brochure from Mentor itself. This is the advertisement, as you can see over here. They're advertising the good Mentor breast implant, but over here, as you will see, the boxed warning, it says, and I quote, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So it's telling you they're not lifetime devices. The second thing, and the longer you have them, the higher the chances are they're going to have problems. So yesterday I talked to a lady. She had implants just 6 years, and she had an MRI proven rupture of the right breast implant at just 6 years. And I want to go ahead and highlight here again, quote, the health consequences of a ruptured silicone gel filled breast implant have not been fully established, period. MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture, quote unquote. Silent rupture means that the patient has an excellent exam, normal exam, and lo and behold, when the surgery explant occurs, the patient has had a ruptured implant, and neither did the patient nor the surgeon. You cannot do an exam, a physical exam, and conclude definitively with certainty that the patient has a rupture. The only way to find out is on the day of the surgery when the explant is done, and you have an MRI test that is not perfect. It still is false negative or false positive, but this is the best test that exists in MRI without contrast, no radiation, no contrast, to look for what is a silent rupture. The other thing I want to highlight, again, this is all objective. This should not be news to the patients who have implants, who have implants, because this is part of what your plastic surgeon must have discussed with you as you got your augmentation. The other thing over here, quote, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others, period. Now, I want to go ahead and stop here. This is what you call breast implant illness. So for a surgeon or a doctor or someone to say that breast implant illness does not exist, I beg to differ, because this is what it is. Joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others, period. Quote, individual patient risk for developing these symptoms has not been well established, period. Some patients report complete resolution of symptoms when the implants are removed without replacement, close quote. So they're telling you that the implants, certainly a breast implant illness does exist, and that if you remove them without replacement, that is essentially the cure, complete resolution. Now, I want to go ahead and mention that whatever abnormal is found is removed by the surgeon and must be sent to pathology, because if it's not sent to pathology, one might miss what might be a abnormality. So for example, as you will see here, this is a patient who had a mass. This is my patient's pathology report. I've Xed out the names for HIPAA violation due to HIPAA compliance. And as you will see, there was a mass of the left chest. I removed it, and it turned out to be a lipoma, which is the most common benign fatty tumor of the body, if you will. And another patient, for example, had what were residual capsules. That means that the surgeon had removed the implant and partially tried to remove the capsules but was not successful. And so the patient sought me out for residual capsule removal. And you will see it says this is a mass. It shows exuberant foreign body giant cell reaction, granuloma inflammation consistent with silicone mastitis. This is silicone. Mast means breast tissue, itis means inflammation. And I want to go ahead and highlight a third final pathology report that says right breast implant capsule, and it says synovial-like metaplasia. Metaplasia is like a reaction to a negative stimulus. Well, the cells are negatively affected of the wall of the surrounding capsule with calcification and ossification and histocytic reaction to non-polarizable material consistent with silica. That means silica, non-polarizable material, is present within the capsule. And if it's left behind, the inflammation will be left behind. And as you will see, benign fatty tissue consistent with chronic inflammation. And so this is the reason why the capsule must be removed. So this is the essence and goal of the surgery. Anyone can remove implants, but the whole essence and goal and gist of the surgery is to remove that capsule along with the implant and anything inflamed, abnormal, such that you have the freedom and the peace of mind that all of that silicone burden, inflamed burden, or abnormal tissue burden was removed, and that all of it was tested as highlighted earlier. And the surgeon in 2025 should be not augmenting. That kind of authenticates and certifies that the surgeon is a believer of breast implant illness. Because remember, you do not want to be putting in implants and also explanting, because now that basically degrades slash does not authenticate you as a true breast implant illness believer or advocate. Because why would you want to do something and put in implants when you know they're not lifetime devices? Ultimately, sooner or later, the patients will end up getting hurt. And you do not want to hurt, do no harm. That's the take-home message. That's the oath that we took. Do no harm. So your surgeon should be very actively talking about breast implant illness, how he or she is doing the surgery. He should be openly showing the chest wall of the patients that he has removed, so that you have the peace of mind that all of that capsule is removed and that you're not second guessing your surgeon, and that all of it was sent to pathology. The surgeon must have a track record that he or she is doing the surgery right, and that he or she is completely transparent, that he or she, there are 5 ways that you can authenticate, certify, have that confidence that your surgeon is doing it right. Number 1, your surgeon is showing you the high definition videos and pictures of cutting open of the capsule, and also more importantly, the chest wall showing that the entire capsule was completely sincerely removed. Number 2, the length of time. In my practice, I take 4 hours plus minus to remove the entire implant and the capsule completely, definitively. This is a surgery about precision. This is a surgery about definitive care, not about speed. And so it takes me 4 hours. I heard the other day this patient was going to be getting a lift and an explant in 2.5, 3 hours. And I will tell you that is virtually impossible. Number 3, the length of the incision must dictate that must be equivalent to the diameter of the implant. So if you have a 500 cc implant, you can imagine that the incision is going to be approximately 10, 11 centimeters, so that the surgeon can visualize and completely see the floor where that implant was sitting, so that the entire capsule can be removed. And so I see some surgeons trying to do an end block through the nipple, which is impossible, or a small 3 centimeter incision, and they're trying to remove like a large saline implant or a large silicone implant, which is impossible. And the length of the diameter of the implant essentially dictates the length of the incision. Number four, you need to return implants to the patient so that you know the sealant implant was not ruptured or damaged, and that the patient can have mental closure. And five, you need to have a surgeon who has on social media a very clear what's the word authentication, confidence that he or she is a firm believer of breast implant illness, that he or she is not augmenting, and that he or she is describing openly, vividly, transparently, so that the patients feel comfortable signing up with the surgeon, and not in a case by case basis. We hear of many surgeons who, out of goodwill, go into the case, and then when they do find out that the capsule is thin, they unfortunately leave the capsule behind or cauterize that capsule, which we heard of. And these are major reputable centers. So this patient went to the top 5 hospitals in the country, and unfortunately, her plastic surgeon was not able to remove the capsules because they were super thin. Remember, it is the surgeon's mindset, that determination, that commitment, that the patient's recovery is dependent on the surgeon doing it right, doing it completely, so that the patient is given that absolute confidence that the surgeon did the surgery absolutely very right, and the manner as discussed on the consent form, which is the legal bind. Do we have any questions?
No.
Okay, so please feel free to ask any questions. So every Monday we'll try to do this, again, kind of a reinforcement. What you want to do again here, do your homework, follow the Facebook pages, YouTube, listen to the previous patients. That by far is the most important source. Do your homework, do it once, do it right. And you do not want to be doing it or second guessing, or be in a situation where you are not confident about your surgeon. And the second thing is, have your surgeon show you the previous patient's chest walls, complete removal of the implant capsule, so that you have complete confidence that your surgeon is doing the surgery right. And this is, again, my practice. This is what I find. And as you will see across the nation, across the United States and the world, you're finding more and more surgeons who are explanting, and they're writing down total capsulectomy, 100% total capsulectomy as the cure, the treatment. Now, one thing I want to mention is, we had the summit, the Breast Implant Illness Summit, approximately 8 weeks ago, approximately 8 weeks ago, where there was a group of plastic surgeons from all over, from Canada, from all over the United States and Europe and South America, who were discussing, what is the proper explant technique. And, that is true. And this was part of the discussion. Does every patient need a total capsulectomy and block? And the answer is, not every patient, but you do not want to be that patient where a patient who partially recovers and now seeks out a second surgeon who's going to now remove that capsule. You want to do it right first. You want to do it completely. You want to do it definitively. You want to do it with that absolute peace of mind and confidence that your surgeon's going to remove the whole capsule, and that in that case, if the implant is ruptured, it's all contained, none of the silicone spills into the chest, and that all what was removed was tested, so you rule out all the badness, any of the irregularities, abnormalities, and that you have given your the best chance for recovery, so you are not second guessing. So if a patient recovers partially, she may not know if that was a complete recovery or not. And this is where, as you will see, the many patients, like this one patient, she said that she was worse after her explant, and that now she really wants to go ahead and remove the residual capsules, because she knows that she has the poison, if you will, the silicon toxicity that remains behind, that needs to be removed, because they have excluded everything else. Now, I just want to go ahead and mention, tomorrow morning at 6 in the morning, I have a call to Hungary, Eastern Europe, a patient that's come to me from out of town. Many patients ask me, is it safe for me to travel? And I'll tell you, it is certainly very much safe. This last year in 2024, I've had a lot of patients from out of town. Almost a good 2/3 of my patients come to me from out of town, out of Michigan. They travel the long distances to get the surgery that they need. And again, this is that complete transparency. I just want to mention that I have no disclosures. I have no financial commitments with any suture companies, any implant manufacturers, as you can imagine. Conversely, I don't have any commitments with anyone, with no Facebook group owners, with no book writers, none of these other influencers. My only commitment is to the patient. to make her feel better, to make her healthier, to be completely transparent, so that when you do get your surgery done, you can see for yourself when you get the pictures and the videos that complete capsule removal was done, and the only interest was the patient's health. There are so many patients that I've talked to who feel uncomfortable, for example, that, because I don't do the lift. You will see first and foremost from my own patients that even with the patients who have had 1,000 cc implants removed, with the excess skin that was removed, with the internal sutures that I put in order to lift the breast tissue up towards the midline and up, and with the fluffing effect, and with the 5, 10, 15% muscle mass that is added to the chest when the patients work out, and between the 30% or 40% of the skin that recoils as the inflammation subsides and as the young tissue settles. Even with the many patients in their 40s and 50s, the lift is not required in the vast majority of the patients, and there are times where and lift is not advised at all, because you do not want to end up getting wound dehiscence, skin necrosis, among other problems. And as you will see in my practice, the need for the drains is not there. It's been well over 5 years that the drains have not been utilized. Number one, I can answer this question in many ways. If the drains were needed, my patients would then have sought out other interventional radiologists or doctors who would have put drains, and they did not. The drains were not required because the blood loss in well over 99.5% of the time is less than 5 cc's. As you will see that the surgery is done below the muscle in the vast majority of the patients where the implants are below the muscle. The dissection is done in a very pristine, slow, controlled, intricate, delicate, sophisticated way, such that there is no oozing. All of that inflamed tissue plus capsular tissue is removed, leaving behind good, healthy, viable tissue, so the need for the drain is not there. Conversely, those patients that require the drains, the surgeon rushed to the surgery, or the capsule was cauterized, or the silicone spill into the chest. Now the drains become mandatory. And you will see, unfortunately, the drains are there in the patients for not only 2, 3, 4 days, 1 week, 2 weeks, sometimes up to 3 weeks. And you see the significant others pulling drains, which I find is malpractice and absolutely wrong. Only the surgeon who put the drains in needs to be the one who's removing them. So as you can see, I even presented a couple of years ago at a Icoplast conference in Dubai of my 1,000 explants, and I showed that the drains that I'd placed were only needed in only 7 of those patients out of the 1,000, and those 7 patients, they had a ruptured silicone implant free floating that she had because of the car accident she was in, and she had blood and silicone in her chest. Or another patient where as soon as I made cut, there was extra capsular rupture of silicone. And so those patients certainly mandate placement of drains. But as you can see, it's been well over 5 years since I've used drains in any of my patients, even with the many 800 cc implants, ruptured implants, because the need for the drain is not there, because all of the inflamed tissue is removed. And this is where the patient is given the best chance to bounce back. And conversely, the drains themselves, they stimulate to an extent small amount of fluid formation. The drains themselves can be hurtful, where if the bulb syringe opens up, that fluid can drain back into the chest. That can be a catastrophe. Or if the tubing of that drain in itself slides in and out, if that drain stitch gives way, then we do not want that to seed the bacteria into the chest. And as you will see, the drains truly are not required. The burden is not on me as to why I don't use drains. The burden is on all those surgeons as to why they use drains, because you certainly can do without the drains. Now, do you have
I
a
have a
question?
couple questions.
Yes,
Yeah,
please.
so first one is, this patient found this fungus, and is that creating her sickness? She didn't specify that if she still has implants or not, or if it was found during her explant.
Correct. Now, once the
And that
fungus is found, you have to find out what the source is. So it could be within the sputum in the lungs, maybe from a mold in a basement that might be present. This may be present on an immunocompromised patient who is on transplant medication or is a bad diabetic, for example. You have to be able to find the source of that fungus. You may have the fungus on the nails, and that is superficial and external. You may have yeast over on the skin folds that can occur on patients with a high BMI, just like in the pannus. And so you have to find out what the source of the fungus is, and this is where you go, or is it in the blood? And so this is very important. And in a situation like this where you have an active fungus, you have to confirm by doing repeated cultures that this is true, and you have to go to an infectious disease doctor. So if you're the president of the United States and you got a fungus, you have to go to the infectious disease doctor who will confirm that you indeed have fungus. What was the source? Where it is where is the location? Do you have fungemia? Is it in the blood? Is there a source? Do you have another hardware that's secondarily infected, if you will? Now, if is the infectious disease doctor then will dictate and direct the antifungal therapy. And if you do have implants, in my practice, as you will see, there's three ways of confirming if you have fungus around in the chest breast area or not. Number one, this is not a normal area where fungus grows. So having said this, grossly as I'm dissecting, if I see black or abnormal tissue that looks dusky black, dark brown, then grossly or abscess pus, that would be suggestive of pus. Number two, I take cultures for fungus and I send it off to the microbiology lab, and they grow it on a dish for 4 to 6 weeks, and that will be a ultimate way of confirming if this was fungus or not. And I take my cultures in between the capsule and the implant, so those are very much representative of the tissue, the biofilm that is present in between the implant and the capsule on the table once the patient is closed. And number three, when the pathologist, the MD, looks at the capsule, he or she can see the septae or the fungus within underneath the microscope, and he or she can alert us. So in those patients where the fungus was found on my cultures, I send the patients directly to infectious disease, and infectious disease then takes it on from there. For me, I've removed all of that bad, inflamed, irritated, angry, abnormal tissue. So for me, the surgical, from the surgical aspect, the patient is clear and free of any tissue that needs to be removed, because all of that tissue has been grossly removed. And this is that care and the sophistication. And then I leave it up to the infectious disease doctor. So one of my patients, she ended up getting IV therapy, antifungal, for a 6-week period through a PICC line. Two of the patients ended up going to see infectious disease doc, and because the chest was clear, the blood tests and the blood cultures were negative, so there was nothing else extra that needed to be done, and the patient was essentially managed post-operatively by the infectious disease doc without any intervention. There were a couple of other patients last year who had fungal cultures positive. They followed up with their primary doctor and infectious disease and certainly were cleared. And from the last that I heard, there was no true antifungal therapy that needed to be done. Remember, the treatment of choice is removing the implants and the inflamed tissue, which is always done in my practice.
Yeah, so she confirmed that it was her explant tissue.
So this is where you should go to your infectious disease doctor, and you should go to your infectious disease doctor and have your infectious disease doctor basically follow you. And this is where further test workup needs to be done by the ID doctor, and confirmation of complete total capsule removal needs to be also done, because that is going to be part of that removal of any abnormal tissue where this fungus was present, which was around the implant, which always involves what is the capsular tissue. Because remember, the capsular tissue is essentially scar tissue. Anytime you have any foreign body within the human, be it a pacemaker or a port for chemoport or a screws or plate or a hip joint, you form what is a capsular scar tissue around, just like with the implants. And that inflamed tissue harbors within it the biofilms at times. So in my practice, I always send the cultures off for aerobic, anaerobic, and fungal. So in my practice, 10-15% of the time, I see bacterial biofilm like Propionibacterium acnes. That's been the most common organism in my practice. Also seen by other plastic surgeons who send cultures off, and sometimes staph epidermidis, sometimes other subsections. And the treatment again here is complete removal of that inflamed scar tissue, abnormal tissue, along with the implant, such that there is no inflammatory burden left behind.
Okay, we have another patient who's having coccyx pain. Is that of the chest, Dr. Khan?
So this is the lower tailbone, and this is
Okay.
where you
Oh,
need to
lower
go.
tailbone.
Yeah, so
Okay.
tailbone. Now you need to go see an orthopedic surgeon, neurospine, orthopedic spine, because that may be a separate independent etiology. Now, as you will see, just like I highlighted earlier, a lot of patients have complained of joint pain, neck, back pain, lower back pain, upper back pain. This is one of the hallmark features, the rheumatological joint problems that the patient come in with. You want to make sure that the coccyx area is evaluated, which is the tailbone. This is where the orthopedic surgeon might get imaging, an exam, and this might be an independent variable. Now, once the orthopedic surgeon says that everything is fine, there's nothing, no intervention, then you can potentially blame the implants because of the many patients who have lower back, neck, back pain, shoulder pain, fibromyalgia type symptoms. And then only when the implants are removed properly, adequately, then only will you know definitively if it was the coccyx or not. But it is not normal to have coccygeal pain. Coccygeal pain needs a definitive workup by an orthopedic spine doctor who specializes in the spine bones.
And she also wants to know if you've seen this before. Her MRI looks good and she's had implants for 12 years.
So I will tell you, patients complain of, as you will hear, don't listen to me, listen to the patients. The patients complain of neck, back, shoulder, lower hip pain. This is where you will hear the many patients state post-operatively resolution of their symptoms. These are the many patients who have also been to pain specialists who have gotten steroid shots, whatnot else, and they have not improved. And so you will hear the many patients that they will have resolution of their neck, back pain. Not all, but this is where it is essentially a diagnosis of exclusion. So I have not specifically heard of coccygeal pain, but certainly hip pain. I have seen and heard from the patients the resolution of that pain post-explant.
I don't have any other questions.
Okay, so I want you to go ahead and continue to follow. Again, if I may impress upon you three things. Number one, do your homework, do it right, do it once. You do not want to be going back to another surgeon who would unfortunately try to attempt to, because he or she is not totally sold on what is breast implant illness and a proper explant. Remember, there are a lot of plastic surgeons who claim that they would be able to do an explant. You want to see their track record. You want to be comfortable. And again, you want to have that peace of mind, confidence talking to the plastic surgeon directly, not to the nurse practitioner or the PA or the medical assistant or the office manager who has no surgical experience. You want to talk to the surgeon directly. Remember, in my practice, I talk to my patients. I only know what happened to the patients pre-op, during, and after, and I'm very much hands-on. I'm not that fancy like a 902 or 10 kind of a doc who's all about style. And, this is where you want to be very much hands-on. You want to be very much, I do almost 6 or so of these surgeries a week. And this is where, as you will see, the many patients, I'm very much hands-on. I know the details. I read the operative notes. And this is where I only know how to and what to manage the patients post-op. The second thing is you want to ask your surgeon to show you the chest wall showing complete removal of the capsule. And there is no harm. Remember, all plastic surgeons have cameras. This is how you can tell a plastic surgeon apart at the hospital from the many other surgeons that exist. A plastic surgeon always carries his camera, and they are required to the point where you even have tests and exams on how to take pictures. So before, during, and after. And this is how you tell that the entire the chest wall is free and minus that capsular tissue. This is where the fascia of the pectoralis minor, the fascia of the serratus anterior, fascia of the intercostal muscle, along with the periosteum, that's the layer directly on top of the rib, and layer directly on top of the chondrium, the cartilage part of the rib, is removed completely so as to confirm complete removal of the capsule. And the last thing I want to mention is my technique, my philosophy, my mentality, and this is where you have to seek your surgeon out so you understand what is in his or her head. You understand, you feel comfortable. It's like you already know your surgeon. And this is where no drains, like we talked about, no need for the unnecessary lift. The pictures, high definition videos of not only the cutting open of the capsule, but also the chest wall showing complete removal of the capsule on top. Number 4, the implants are returned to the patient. Number 5, culture done for aerobic, anaerobic, and fungal. Number 6, the capsules are always sent to pathology, rule out the BIAL, CL, CD30 analysis. Very rare, rule out breast cancer, rule out any abnormal pathology. Number 7, twilight sedation, where the patients get propofol, fentanyl, Versed, and complete amnesia to the event. The patients are not awake, they have no recollection, they are deep asleep, in deep sedation, what they call IV general, and they're not paralyzed and they're not dependent on the ventilator. This is vast majority of the patients, if not all. And number 8, you will see that every patient, regardless of the comorbidities, regardless of the many other medical problems that they may have, the patients get the same surgery. So if a patient has bad COPD, she'll be done at the hospital. If a patient is old and has cardiac issues, she'll be done at the hospital. Once the patients are determined to be safe, there was a patient that asked, well, I want to see an MD doc who's going to be my anesthesiologist. Well, guess what? At the hospital, the CRNAs are the ones who are literally in every case. And if there is ever even a question mark, if the patient needs to be done at the hospital, I do the patient at the hospital because I do not like to take chances and I want to be very firm and very thorough. I review the chart independently. I talk to the patients initially and screen the patients. My CRNAs also look at the charts independently, and my nurse also looks at the charts independently so that there's a check and balance and every patient is looked into very seriously. There's the verbal feedback from the patient, and then there's the MD medical clearance. So yesterday I talked to a patient who's seen by a primary care doctor and also by a pulmonologist. So I await the information from the pulmonologist as well so as to clear the patient so that I know that the patient is overall meets criteria for what is outpatient surgery at a quad A, which is the highest level gold standard of operating rooms outside of the main hospital. So having said this, please get your questions ready. I'll be doing a Facebook Live with one of my patients from Europe towards the end of the month. She's the one who had an initial explant and then an attempted residual capsule. And then I came in for her third surgery to remove what was residual capsule removal. And we will hear from her improvement and the many symptoms of what is breast implant illness, and we'll hear from her as to why she made the effort. We have a lot of thoughtful patients who share their journeys. Remember, this is a movement by the ladies for the ladies so as to improve the lives of the many patients who are hurting from breast implant illness. The many ladies, unfortunately, do not know that the detrimental effects of the implants, which is what I read earlier, which is very well known. And I want you to continue to ask your questions, have an inquisitive mind, be open-minded, be very professional. All what we're trying to do here is raise awareness so that if you are hurting and you have sought out so many different doctors and you continue to have the many symptoms of what is suggestive of what is breast implant illness, and you can put the two into together intuitively, and because you have ruled out all the other problems, then by default you have more and more fingers pointing towards what is breast implant illness. So having said this, it was a pleasure to do the first Facebook Live, YouTube Live, TikTok Live, and Instagram Live this year in 2025. We look forward to a very productive, informative year where we are going to hopefully continue to answer the many questions. Please continue to follow, spread the word, share with the other prospective patients. If you're a patient wanting to and consider implants, there is no other better site than this so that you can get all of your questions answered before you sign up for a surgery, which will ultimately require potential more surgeries, just like using the words of the FDA and by the manufacturers. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery, quote unquote. Thank you very much. Take care and all the very best.